Today we are joined by Minister Jones, Interim CEO of Acute Care Alberta, David Diamond, Chief Medical Officer of Acute Care Alberta, Dr. Aaron Lowe, Interim Chair and CEO of Alberta Health Services, Aaron O'Neill, and CEO of Covenant Health, Patrick Dumali, here to discuss acute care capacity. With that, we will start the press conference, and we will hand it off to Minister Jones to start. Minister, please go ahead.
Thank you. I want to take a few minutes to provide an update on the activity in our hospitals and the steps we are taking collectively to support safe and reliable care across the province. Our major hospitals, especially in Calgary and Edmonton, have been experiencing significant pressures over the last several weeks. Emergency departments have and are seeing higher volumes of respiratory illness, more complex patient needs, as well as the usual winter illnesses that increase demand across urgent and emergency care. Inpatient units have been operating at high capacity, and teams have been working around the clock to keep patients moving. I sincerely thank them for their critical work. The Government of Alberta and our health agencies and service providers have been actively coordinating a province-wide response daily that has seen all sectors of the healthcare system cooperate to create capacity and free up resources. In the Edmonton area, hospitals are implementing measures to preserve emergency department capacity and improve patient flow. These include accelerating discharges and transfers where appropriate, upfront diversion to recovery and social supports, limiting non-essential inbound transfers, dedicating 336 beds specifically for respiratory virus season, transitioning alternate level of care patients to more appropriate care settings to free up hospital beds, and opening designated surge spaces to manage increased demand. I'm pleased to share that this work has resulted in the system only needing to rebook a handful of surgeries, 8 this calendar year. For perspective, our system performs roughly 6,000 surgeries per week. Hospital and emergency department pressures are very real. Along with the seasonal rise in respiratory virus season, our high population growth, our aging and more medically complex population, and even cold weather all exacerbate these pressures. Fortunately, we are now beginning to see signs that the situation is easing from the peak seen in late December. Respiratory admissions are trending downward. Influenza activity has declined, and emergency inpatient numbers have improved across several high-demand sites. These early signs are encouraging. We're down to 675 respiratory virus patients from the late December peak of about 1,000, and our emergency inpatients have dropped by 100 week over week, down from peaking in the mid-500s. As conditions improve, we're not slowing down. We're strengthening the system to ensure it's resilient now and into the future. Through the Acute Care Action Plan, Alberta is adding more than 1,000 hospital beds in Edmonton and Calgary, including new bed towers here in Edmonton, at the Grey Nuns and Misericordia, and at the South Health Campus in Calgary, which will expand regional capacity and designated surge spaces that can be activated during high-demand periods like respiratory virus season. We've also announced the site for the standalone Stollery Children's Hospital, and we continue to build the Red Deer Regional Hospital expansion. We are also expanding community-based care, key to moving additional alternate level of care patients and key to freeing up hospital beds. The Assisted Living Framework announced last month by Minister of Assisted Living and Social Services, Jason Nixon, invests $400 million to add 1,500 new continuing care spaces. This builds on our government's strong investments in psychiatric beds and reinforces partnerships that help transition patients from hospitals to more appropriate care settings. Reducing the number of patients waiting in acute care for other types of support is essential to keeping emergency and inpatient units functioning safely. Urgent care centers continue to play a key role in diverting lower acuity patients away from hospitals. We're investing $17 million to advance 9 new urgent care facilities across the province. These investments will help to ensure people get the right care more timely in the right place. Albertans can support the system too. Staying home when sick, getting vaccinated, and choosing the most appropriate care option all help to reduce pressure. For non-urgent concerns, family physicians, urgent care centers, virtual care, home care, and HealthLink 811 can provide support, care, and advice. I want to close by thanking the dedicated teams of healthcare professionals across Alberta, as well as Acute Care Alberta, AHS, and Covenant Health, for their exceptional day-to-day work, which has been instrumental in getting us through a very challenging and busy respiratory virus season and ensuring that patients continue to receive high-quality care. We remain focused on strengthening capacity, improving patient flow, and making sure Albertans receive the care they need. I would like to now invite David Diamond, Interim CEO of Acute Care Alberta, to speak next.
Thank you very much, Minister Jones, and Good afternoon, everyone. As Minister Jones has talked about, the province, Alberta, is currently navigating a particularly challenging respiratory season, which has placed considerable pressure on an already stressed emergency departments across the province. And we understand that in the front lines in hospitals, this has been a very difficult time, and we appreciate the ongoing work that frontline folks, particularly in emergency departments around the province, have done to care for Albertans. These challenges, of course, are not unique to Alberta. Acute care systems across the country and around the world are grappling with these same impacts. I'm here today to provide a bit of an overview of where we currently sit in terms of overall system capacity and to outline what actions Acute Care Alberta has been taking and currently are taking to ensure that all Albertans get the care that they need when they need it. Firstly, at the moment, I think as of this morning, our inpatient occupancy in the province's large hospitals is at 102%. And so, as you can see from that, when you get above 100%, it reflects the pressures that we're still under. So, despite the, we have the improvements that we've talked about. The Minister talked about the trending in terms of flu, trending in terms of hospitalization as a result of respiratory, and that's all really in a good direction. But, for the next short period of time, we still have pressure, and we really appreciate the staff and the impact and what people are doing. So 102% of occupancy across the province's 16 largest hospitals. This figure includes temporary and surge spaces that are currently open to meet the needs of demands in this period. The respiratory virus hospital admissions are down from a peak of 995 at the end of December to 675 today. And for context, during the peak of the COVID-19 pandemic, our acute care system was able to accommodate approximately 1,600 patients. So while hospital admissions due to respiratory illness are declining, we still see a high volume of non-respiratory hospitalization, which puts sustained pressure on our emergency departments and our hospital units. Planning for respiratory season this year actually started last summer when ACA, the newly formed Acute Care Alberta, started work with AHS and with Covenant and the centre in Lamont to identify additional beds that could be used for additional capacity for seasonal surge in demand as a result of respiratory viruses. As a result, across acute care, 206 new spaces were permanently funded this year, with an additional 130 seasonal surge spaces that have opened to help address capacity pressures. A detailed surge capacity plan was also updated. Alberta Health Services, in the previous iteration of the system in Alberta, had a surge plan, and so now in this new refocus system, we've taken that plan. We work with Alberta Health Services, we work with Covenant, we worked with Lamont, and so we updated that plan over the course of the fall to ensure an understanding of how our new refocused acute care system could respond to surge capacity. Before the holidays, we also received modeling data from the University of Alberta and the Institute for Health Economics, identifying that this flu season would be particularly difficult in terms of the projected numbers, but also projected a peak of cases around the 27th of December. And this was particularly helpful for us because one of the levers that we have as an acute care system to be able to address this additional demand is to reduce surgeries. And over the Christmas period, we have a natural reduction of surgeries. And so we didn't have to cancel surgeries or reduce the number of surgeries because the peak was happening through the Christmas period. Acute Care Alberta has also been working closely with our partners, AHS and Covenant Health, and coordinating a provincial response to these capacity issues. And so in this coordinated response, we're working with our providers to support the work that's happening at the local site and corridor level. And we meet with AHS and Covenant leadership on a daily basis to coordinate our provincial response. This dedicated team meets every day and also includes our partners from assisted Living Alberta, Primary Care Alberta, Emergency Health Services, and so on. So part of our role in this system is to coordinate all of the players so that every day, several times a day, we're together around the same table with a coordinated provincial response to capacity planning. The Minister talked about surgeries, and so well, I've talked about surgeries, and maybe I'll leave it there. In addition to managing surgeries and having a provincial response, we have continued the usual approaches in the surge plan around load leveling. The Minister talked about centralized coordination to decision making, repatriating patients from beds in places like Alberta to rural sites, and working with ALA on quite an aggressive plan to repatriate ALC patients from hospitals into continuing care. These are just the few of the ways that we're working daily in a coordinated fashion to manage the capacity challenges. And as the Minister talked about, and I'd like to add our thanks as Acute Care Alberta to the many frontline staff at AHS in particular, and Covenant Health and Lamont, and our other partner agencies, and of course in ACA as well, who have been working tirelessly through this season to try and coordinate as best we can to keep people safe. We see so many of our dedicated doctors and nurses and other frontline staff going above and beyond every day to meet the demand for services, and I want them to know that their work does not go unnoticed or unappreciated. I'll now turn the podium over to Aaron O'Neill, who is the interim CEO of Alberta Health Services, for a few words.
Thank you, Dave, and good afternoon, everyone. I'm pleased to be here today on behalf of Alberta Health Services. I want to start today by acknowledging the incredible work our frontline staff and physicians have been doing. While it's common this time of year to see an increase in demand due to the colder weather and respiratory viruses, our sites across the province have seen a higher sustained demand than normal. Our emergency departments and sites have been exceptionally busy. Our teams are going to extraordinary measures to meet the day-to-day demand of those needing emergency medical attention while maintaining surgical volumes. So first and foremost, I want to recognize staff and physicians for their hard work and ongoing commitment. I know it has not been easy. While we are doing our best every day to be available for Albertans, the system is feeling the pressure. As part of our efforts to meet these demands, AHS has been working to expand capacity where we can. In addition to adding more permanent bed spaces, as Dave mentioned, sites are working together to address demand at specific sites by load leveling. This can include redirecting ambulances with less acute patients to other facilities to preserve capacity at major urban hospitals. Corridors are also working together with our partners in our health agencies to repatriate and transfer patients around geographic boundaries to the most appropriate level of care. This includes working with emergency health services to return patients who no longer need specialized care from larger centers to other facilities when medically appropriate, or transferring patients to alternative levels of care when they are no longer require an acute care stay. These are some of the examples of how we are responding to demands and how we remain ready to take additional steps as needed. There's been a lot of interest this week in the University of Alberta Hospital and the adjustments required to accommodate the much needed expansion and renovation of the Adult Neuroscience Intensive Care Unit. This project has been an Edmonton priority for more than a decade, and it is only one unit. It is the only unit providing this level of brain care for Edmonton, Northern Alberta, and beyond. This modernization will increase the neuro ICU from 11 beds to 24 beds in single patient rooms. It will make a huge difference for future patients and their families. The University Hospital Foundation has been a critical partner in the project and will be contributing $17 million to the build as part of its $70 million brain center campaign. The new expanded neuro ICU is only possible by moving other units. When you have a footprint that cannot be increased, unfortunately, hard decisions have to be made about what services will remain at the site. The University of Hospital is home to many specialized programs that are only available at that site. Those programs serve critically ill patients who cannot receive the same level of care anywhere else. This means that there's limited options for which services could potentially be relocated. Factors that were considered were patient acuity, the type of care patients require, physical infrastructure, and financial impact. It was ultimately determined that one of the family medicine units at the University Hospital was the most appropriate unit to move off-site. The closure of 4 beds this month on 5F2, a family medicine unit, will allow for some minor renovations that are required as a next step in the neuro ICU redevelopment. This spring, the 21 beds from the family medicine unit at University Hospital will be relocated to the Leduc Community Hospital pending finalization of the operational plan. There will be no funded bed loss within the Edmonton area. There will be no AHS job loss. Employees will receive appropriate notice of the relocation and will be afforded rights under the respective collective agreements. We are aiming to preserve the physician practice with the move to the new location. Once relocation plans are finalized, we will develop and share a detailed plan outlining next steps, timelines, and support for staff and physicians. We know this decision is of concern to those who work in the unit, and we will work with physicians and members of the multidisciplinary team to understand and address their concerns. We are confident that this decision will ultimately have minimal impact on the care the family medicine patients and families receive. We are also confident that the expansion of the neuro ICU will have a huge impact on the care and environment we will be able to offer future neuro ICU patients and their families. Thank you, and I'll pass it over to Patrick from Covenant Health.
Thanks, Erin. I want to thank Minister and thanks Acute Care Alberta for really the unprecedented collaboration and leadership that they've shown during this challenging time for our health system. I also want to speak directly to the family and friends of those who experienced loss during this extreme circumstance. I can only imagine how devastating and overwhelming that's been. And so on behalf of Covenant, I want to offer my condolences. Please know that your loved ones were not just patients to us. They were people, they were families and friends. Their deaths are deeply affecting our care teams, our leadership, and the entire organization. This has been a very difficult time for staff, physicians across Alberta who show up every day for the people in moments of fear, pain, urgency, and this weighs heavy on all of us. They are, as all Albertans are, deeply distressed by the situation. The reality is that Alberta's emergency department and acute care hospitals are under extraordinary pressure. These pressures are not isolated to one organization or one site. These pressures reflect system-wide demand, as we've heard, driven by respiratory illness, population growth, aging, and the increasing complexity of care that we're seeing facing our caregivers in our hospitals. In matters like this, what matters most is how we respond and how we respond together. We've had the opportunity to review the recommendations from the Quality Assessment Review conducted by Acute Care Alberta, and I want to say that we are in 100% alignment and committed to implementing them. Both the recommendations that are specifically around the Grey Nuns Hospital and will improve care at the Grey Nuns Hospital, and also those that we'll be partnering with in terms of system-wide response. We commit to honoring the lives of those lost by responding with seriousness, urgency, accountability, as the situation demands. Covenant Health's role in the system is to be a trusted, accountable partner. We are committed to working closely with the province, Acute Care Alberta, AHS, and other health partners to improve capacity, strengthen patient flow, and ensure Albertans receive care in the right place at the right time. Our physician, nurses, and healthcare teams are deeply committed to that goal. They show up every day with professionalism to deliver quality care with compassion and dignity, even when conditions are difficult. I want to acknowledge my appreciation for what the province is already investing in adding much needed capacity to the Edmonton zone. we are actively working on adding new patient bed towers to both the Grey Nuns and Misericordia Hospital. This will add 700 beds to the zone and double the capacity of both those hospitals. We are also working closely with the province on our new Covenant Wellness communities. The first one is opening in southwest Edmonton, and these don't replace the need for hospitals, they make hospitals work better. We've already started moving outpatient clinics out of the Grey Nuns Hospital into the community, and that frees up space inside the hospital for things that can only happen there, especially expanding our emergency care. At Covenant Health, our mission is rooted in compassion and respect for human dignity. Those values guide how we care for people, how we support one another as teams, and how we approach the responsibility within the Alberta health system. We recognize that no single organization can solve these pressures alone. That's why we are strongly support the collaboration, province-wide approach led by the Minister and Acute Care Alberta. This approach focuses on expanding capacity, improving flow, strengthening continuing care, and diverting care appropriately into community settings. We also believe that the future of healthcare in Alberta depends on partnerships that are practical, respectful, and focus on solutions. Covenant Health is committed to being part of that future. We will continue to work with government as system partners to help relieve pressures on hospitals, improve transitions of care, expand community-based options, and support our frontline teams as they care for Albertans under what are often very challenging conditions. Above all, we remain committed to doing the work with humility, collaboration, and a sense of responsibility for the people we serve. Thank you.
Thank you. Now I'd like to speak to the circumstances around the death of Mr. Sri Kumar. And first, I want to once again offer our deepest condolences to his family and friends. His passing at the Grey Nuns Community Hospital is a tragedy felt across Alberta. While there is no doubt that pressures in the system, and specifically at the Grey Nuns Emergency Department, on December 22nd impacted care, after reviewing the information available to me with advice from clinical experts, I have concerns and unanswered questions about the circumstances surrounding Mr. Sri Kumar's death. While system-level improvements are underway, a detailed, independent, and public review of how the specific case was managed also needs to be undertaken. We owe that to his family and to all Albertans. As such, I have asked the Minister of Justice to order a fatality inquiry. Minister Amory has confirmed that he has accepted the request and initiated the next steps to proceed. A fatality inquiry is a public and transparent process. It will take place in the Court of Justice and can be observed by the public. Following the inquiry, the Justice will provide a report to the Minister of Justice, setting out findings about the circumstances of the death, and this report may contain recommendations as to prevention of similar deaths. The public fatality inquiry process will gather information and question appropriate witnesses in order to fully understand what occurred. To provide additional support, we will immediately be trialing a new triage liaison physician role. These physicians will be added immediately at the busiest emergency departments in Calgary and Edmonton, where they will work directly alongside triage nurses and emergency physicians to expedite assessments, support diagnostics, and begin care for patients in the waiting room where appropriate. Phase 1 will include the Royal Alex Hospital, which already is approved, the University of Alberta Hospital, Grey Nuns, and then the Foothills, Peter Lougheed, and South Health hospitals in Calgary. Throughout my visits to Alberta's hospitals and my many conversations with physicians, this was an initiative they strongly supported, and I'm pleased to implement it immediately. To Mr. Sri Kumar's family and friends, you have our condolences and our commitment to a thorough, independent, and transparent review of the circumstances surrounding his death. Trust and confidence in the healthcare system is essential. I want to be clear that our government trusts our frontline healthcare workers and hospital providers. And Albertans should continue to have confidence in the care they will receive when and where they need it. We will continue to collectively take steps, both immediate and long-term, to strengthen capacity, improve flow, and support the teams who care for you. Thank you.
Thank you, Minister. That brings us to the end of the speaking portion of our news conference. We'll move to the media question and answer. We have time for one question, one follow-up. We'll ask the media to identify yourself and your outlet, and we'll start with the room here. I saw Lisa, your hands up.
Thanks. Lisa Johnson with the Canadian Press. I'm wondering if you can speak to some of the concerns that doctors have been raising. They've been calling for some very specific things, and they've also suggested that since the restructuring, no one is really in charge of, or nobody seems to be in charge of integrating operations across hospitals and corridors. Who is directly accountable for managing patient loads across agencies and corridors? Is it Acute Care Alberta? Is it you, Minister? Can you please explain to me the structure of how that works and why there's confusion there?
Thank you. Well, first, there is no one person who runs a $28 billion complex integrated healthcare system. And as you've heard today, Acute Care Alberta, government ministries and departments, and other agencies like Assisted Living Alberta and service providers like AHS and Covenant and Lamont all work together on a daily coordinated basis to provide the care to Albertans, whether it's in hospital or in continuing care or in community. So there is province-wide coordination. There always has been, there always will be. And I would say that it's the only reason we've gotten through the bulk of respiratory virus season the way that we have. It was very difficult. There are still pressures today, but you did not see mass surgical cancellations or sites closing. And that is a credit to frontline healthcare workers, but also a credit to the coordination by Acute Care Alberta and the other agencies and the service providers and the government ministries and departments.
And kind of related to that, there's also some dispute about the data that you've been sharing throughout the past little while here. There doesn't seem to be a standard, a clear standard about how patients are classified in emergency rooms and hospitals. So there's emergency inpatients who can't get admitted to the hospital, get upstairs, but some hospitals seem to be using different labels for those patients. There's transfers waiting assessment, still taking out beds in the ER. You've shared numbers about ALC patients, alternative level of care patients. But when I talk to doctors, they say that they're being recategorized as something else, which is skewing the numbers all over the place. Is there anybody, is Acute Care Alberta, or is there anybody who's responsible for standardizing these labels so that we can get a clear picture of how many patients, how many ALC patients there are across the system at all? Like who is standardizing that? Is anybody standardizing that, or are these labels just meaningless?
First, on the ALC question, I have heard this concern about patients being classified or unclassified as ALC patients. I've asked for examples when this has been raised with me, and I've yet to be provided examples. If that is happening, anybody watching is invited to share that with my department so that we can investigate. But to date, we have not been shared an example of that. We are standardizing metrics across our healthcare system, particularly in acute care, and we are also committed to publicly and transparently sharing that. So we're going to be launching dashboards starting with surgical data, but then EMS data and primary care data. So the goal is to have standardized metrics that we're all held accountable to, that Albertans can understand and follow, and then to publicly share those on a dashboard. Again, that will be released shortly and built on in the coming weeks and months. It's going to start with surgical data.
Hi, Mr. Julia Wong, CBC National. You've outlined what your government and various health agencies are doing. You've outlined some of the new roles that will be added to hospitals. In your mind, is there anything else that your government could be doing to help ease pressures, to help doctors feel like they're not stretched so thin? And if so, what would it take to trigger those?
Yeah, that's a great question, and there's 100 answers because it is a complex integrated system. So just some examples. On the front end of the hospital system, we're trying to divert people to the most appropriate level of care. So whether that's an emergency department, an urgent care center, or perhaps they could be cared for in their home or community. Perhaps someone presenting to an emergency department could be immediately diverted to recovery or mental health supports outside of an emergency department, or they could be redirected to social supports. In hospital, we're trying to improve flow. And so we're looking at our processes, we're trying to standardize, we're trying to leverage best practices from site to site and enhance the type of coordination that we have really done throughout respiratory virus season. And on the back end, which you've heard a lot about, is we're trying to decant the hospital of alternate level of care patients. So on any given day, we have 12 or 1,300 alternate level of care patients in hospital beds. About a quarter of those are awaiting placement in continuing care. The quicker that we move them to the more appropriate space, the faster we have a hospital bed for someone who requires acute care. So the answer is we're working on well over 100 different initiatives, and there's tremendous collaboration across the government ministries, departments, and again, our service providers to prioritize which ones will have the most impact, and also informing how we allocate finite resources to the best places for patient impact.
And so I do have a follow-up for you, but I also have a second question. My follow-up for you is, would you feel comfortable going to the ER right now if you had to?
Yes, I would.
And so my second question is for the CEO of Covenant Health. We heard that there were 2 other deaths in the Grey Nuns ER the same day that Mr. Sri Kumar died. Is Covenant Health investigating the deaths of those 2 other people who passed away that same day?
Yeah, and regrettably, the emergency department sees some very acutely ill people who, experience heart attacks and other things associated with this. So our routine is that anytime there's an untoward issue or a death, that is routinely followed up. I can say that those 2 other incidents have been followed through on and followed up on, and the matter is I think being well addressed.
And just to make sure I'm clear, because we haven't been able to get any clarity on this, so those 2 other individuals who died that same day, did they also die waiting to be seen by someone in the ER?
All 3 patients who passed away on that particular day were in active treatment, and I think that's probably all I can say about it.
Thanks, Julia.
So what exactly does
Thanks,
that
Julia.
mean?
We'll move on to you.
Sarah Comadino with Global News. My question's for Minister Jones. When it comes to, we're hearing from doctors that the government was warned that this flu season was going to be particularly bad. It seems like what's happening right now is very reactionary. I know there has been efforts made previously, but knowing that this flu season was going to be bad, why wasn't some of this efforts with moving patients out already done ahead of time to ensure that hospitals weren't experiencing this?
So planning for respiratory virus season occurs months in advance of respiratory virus season, and I can assure you that patients were being decanted from hospital who no longer required acute care. For example, since Assisted Living Alberta started a dedicated effort to transitioning ALC patients, they've reduced ALC patients by about 20% across the system. At certain hospitals, that's over 35%. So this work very much did start before and in advance of respiratory virus season, as did our decision to permanently add over 200 beds permanently in anticipation of a busy respiratory virus season, and then we stood up an additional 130 or so surge. So that's not true. There was months of active planning and coordination in advance of respiratory virus season, which is why you have not seen mass cancellation of surgeries, for example, which is one of our levers to provide additional capacity in the system.
The call also for the state of emergency. We know from the government that at this point, that's not wanting to be said. It's also, are you though willing to admit that hospitals are in a crisis right now? Is that fair to say?
Hospitals are under extreme pressure, including the emergency departments, and we need to build more capacity, and we need to continue to add physicians and healthcare workers, absolutely no question. A state of emergency, I think there was a misunderstanding as to what powers that grants the province. I don't need to seize anyone's land or go on it without warrant or stand on the street distributing medical supplies. I have the tools, as does Acute Care Alberta and my ministry and the other agencies and ministries. We do have the tools to appropriately respond to respiratory virus and hospital pressures. And in the event that we would need to escalate to obtain additional powers to manage a situation, we would, as governments have in the past.
Thanks, Sarah. I'll move to Cindy.
Hi, Minister. Cindy Tran with the Edmonton Journal. Just a follow-up to that. So what criteria or threshold would the healthcare system have to be under for you to declare like such a medical state of emergency?
That's a very complicated hypothetical question. I would, of course, be advised by my service providers through the agencies and in collaboration with the other ministries and departments. Again, it's a very large, complex, integrated healthcare system, but rest assured that the government would take all necessary steps to protect Albertans and their healthcare capacity.
Perhaps this is either to you or Mr. Diamond, but it's in regards to hospitals, or the largest hospitals being at 102% capacity. So what is the optimal capacity hospitals should be operating at? Because I'm looking at numbers here and it shows anything above 86% is in the red zone.
Yeah, so typically we would want to operate in the 85 to 90% range. Hospital space is extremely expensive and it's difficult to staff. Of course, every health jurisdiction in North America is seeking more healthcare workers. So 85 to 90%, depending on what area of the acute care system you're talking about, but I'll turn it over to David Diamond to comment further.
I think, Minister, you've answered it well. It is ideally, if we had our druthers, it would be 85 to 90%. Obviously, when we get to 100%, that is when we start to see the kinds of challenges that we have with backlogs in ERs and so on. So 102% is not where we want to be. And that, I think, is, the Minister talked about 100 different initiatives, and there are many things that we are talking to AHS and Covenant and the Minister in his office about things that we need to do. Really, the challenges in emergency, as I'm sure many of you know, are actually have less to do sometimes with emergency departments and how they operate. It's more on the upper end where we don't have medicine beds. And so if you're in emergency and you need a medicine bed and there's no bed available, then you stay in emergency. And if you stay in a bed in emergency, somebody stays in the waiting room. And so there's a range of things that we're talking about. Some of them are improvements that we can do in the emergency. Some of them are about capacity that we need to create, particularly in medicine units. The Minister talked about the towers, which is from Acute Care Alberta's perspective, is fantastic as we think about the future, because that really is the longer term solution. But we are doing some other things. We're looking at after hours coverage for healthcare professionals to make sure we can maximize the beds that we do have. We're looking for more surge spaces, so we created the 206 we funded last year. We think that we can probably squeeze some more of those kinds of spaces, so we're looking at those things. We're looking at a range of things that would add medicine capacity. The ALCs that Assisted Living Alberta are working on is also really important, as the Minister talked about. So a variety of things. Our big focus, I think, in the next period of time, in addition to doing some of the improvement work that we can do in the ED, is actually how do we create more medicine beds, and that's the thing that will create the flow.
Thanks, David. We're going to move to the phones for a bit before coming back to the room here. Operator, can you put it through the first caller?
First question is from the line of Tim Brooke from ZTV News. Please go ahead.
Hi, my question is for the Minister. Minister, doctors have been calling for a state of emergency for 2 or 3 weeks now, and they've been telling us they need some leadership from one or all of Alberta's health ministers. So my question to you is, why did you not feel it was necessary to appear in front of media and answer questions for the public until now?
Thank you. First, on the state of emergency, the reason we didn't call a state of emergency is because we have all tools and authority necessary to manage the system, as we have been in collaboration with our agencies and service providers. And we regularly provide updates to the public on healthcare metrics. And I think today I'm providing the opportunity for media and the public to hear from the leaders at the agency, service provider, and ministry level. And we'll continue to do that. As I mentioned earlier, we're also going to be releasing dashboards with metrics and data on our hospitals, starting with surgical data, then EMS, some emergency department data, and then even primary care data. So it is our goal to be more public and transparent on the realities of our healthcare system through transparent data sharing. And I expect that to be stood up beginning, tomorrow or early next week.
Do you have a follow-up, Tim?
Yes, much like the question from the Global Reporter, we at CTV have been hearing a lot of that word reactionary being used when it comes to some of the measures being announced today. So I guess my question is, how much responsibility is your government taking for the current situation inside hospitals and urban centers?
First, I think it would be unfair to characterize the health system's response to this respiratory virus season as reactionary, because in reality, planning was done months in advance, investments were made months in advance, and really the culmination of that work is that we were able to weather the busy portion of this respiratory virus season the way that we have. It was not perfect. There were challenges. We can, of course, do better, and we will learn and do better. But I think the teams from the hospitals all the way up to the agencies and even my department officials have done fantastic work. And I can assure you they are working daily, every night, to ensure that care is available for Albertans when and where it's needed.
Operator, can you put through the next set of questions, or next caller?
Next question is from the line of Zuma Kampara from Radio Canada. Please go ahead.
Sure, thank you. My question is in regards to the public fatality inquiry. So does this immediate action indicate that the government has already identified systemic failures that go beyond the single tragic incident? And what immediate protections are actually in place for patients while conduct?
No, the call for the fatality inquiry is the result of, from the information that I've reviewed, I fully acknowledge that system pressures broadly and system pressures, pressures specific at the Grey Nuns Hospital play a role. But I also have concerns and unanswered questions about the death of Mr. Sri Kumar that need to be investigated further, and this is the highest level of public and transparent review that is possible, and so that's why I'm calling for it.
Do you have a follow-up?
My follow-up would be for Mrs. O'Neill. It's regarding the relocation of the University of Alberta Family Medicine Unit. How does moving a core family medicine unit out of the city center to a community affect accessibility for patients who rely on the central location? And can you guarantee those patients will not lose access to care?
Thank you for the question. At the University of Alberta Hospital, there's actually 2 family medicine clinics, so both have 21 beds. So we are only moving 1 family medicine clinic out to the Leduc Hospital. The decision was based on patient acuity and the type of care patients require, and we will look and work to make sure that while we move patients around, it is considered of what type of patients will be there, and we are confident that care will remain as it has been provided at the University of Alberta Hospital, and will remain patient-focused to make sure all of our patients are getting the care where and when they need it.
Thank you. Operator, could you put through the next caller?
Next question comes from the line of Catherine Grikowski from All Alberta. Please go ahead.
Yeah, thanks for taking my question. So I'm wondering, what were those recommendations from the Quality Assurance Review, and what are those answers you're still looking for through this judicial inquiry?
Thank you. I did not participate in the Quality Assurance Review, so I'm going to turn that one over to Dr. Lowe. And I would say that I need to fully understand the circumstances around Mr. Sri Kumar's death, and I still have questions that need to be answered. I'm not going to comment because this is going to be a public, transparent, and independent process done by a judge, and I'd like to see that process play out. Dr. Lowe?
So thank you. The Quality Assurance Review, just for everyone to be aware of, is a provision under the Alberta Evidence Act, which allows us to look in a very broad way about what happened in a certain event that was not as we would expect it within healthcare. And so the reason it's protected is because we want everyone to be able to speak freely about what happened. We talked to a number of people who were involved in the care, as well as experts in emergency medicine when we do a QAR such as this. We're not speaking directly to those recommendations because that's under the what's called Section 9 of that act. But broadly, the recommendations speak to things that we noticed in the system that are many of the things that you've heard already, and certainly the triage liaison physician, which is what Minister spoke to earlier, is an important part of kind of how we're going to move forward. And so the other recommendations broadly are addressing some of the things that we know are pressures, such as emergency inpatients in emergency, some of the pressures that we face with these transfers waiting admission, which we've heard about, these patients who are waiting to be admitted to a unit, among other things that affect flow within a hospital. And so those are kind of broad things that we look at that will come from that process.
Do you have a follow-up?
Yeah, I'm hoping you can explain that triage liaison position role. How is it different from what's going on, and what can people expect to see if they're in hospital with this new role?
Yeah, we're really excited about this, actually. So this is work that had been done by some physicians within the province of Alberta, looking at, we have people waiting in emergency departments. How can we best provide care to them, even though we don't have as many spaces as we would hope for those patients to be cared for? And so this is net new work. It's a physician that will work right alongside the triage nurses, and in many cases provide care and beginning of care with patients in the waiting room. This will also allow us to sort of better stratify which patients need to be seen sooner and can't afford to wait, which we know is the case. Whenever a patient comes into the hospital, to the emergency room, they get a score which determines sort of how unwell they are. And so we know that we have patients that have higher scores, meaning they're more sick, more acute. And sometimes those patient waits in our waiting room. And so that physician can focus on this new role, will focus on those patients and provide assessment and be able to better risk stratify and prioritize those patients who be seen earlier. So we're really excited about that and working with physicians to get that going as soon as possible, as you've heard.
Thank you. Operator, you can put through the next call as well.
Next question comes from the line of Zoe Mason from the Medicine Hat News. Please go ahead.
Hi, thank you for taking my question. My question's for Dr. Diamond, and sort of following up on a question that was posed at the beginning here as well. But as one of the previous reporters said, doctors have been asking for some specific measures, and one of those has been patient load leveling that's managed by an entity with authority over all service providers in a corridor or catchment area. I'm curious if one of the entities does have this authority over all service providers, so not collaboration per se, but more like oversight. And I guess I'm curious if ACA is that entity.
Yeah, thanks for the question. First of all, I should say I'm not a doctor, but thank you for that introduction. But in terms of load leveling, and this is where I guess, I do want to respond to that. I've seen in the media and folks have talked about, this is a piece that's missing from our response this year that they've seen in Alberta in previous years, and that's not actually missing. Acute Care Alberta ultimately does have authority to require certain things of agencies. We have not been in a position to do that. We have a fantastic collaborative relationship with AHS and Covenant. We're not anticipating being in the scenario where I have to tell one of those agencies what to do. I suppose ultimately I feel I could and would do that if I had to. We have been doing load leveling from the beginning of this response to the respiratory season. We have moved people around within the hospitals in Edmonton between AHS and Covenant and vice versa. We've worked with our colleagues in rural sites that have had some level of vacant beds and the physicians there to repatriate patients who might be from that area, from hospitals in Edmonton, for example, up north, to protect the bed space that we need to. So we have been doing all of that, and that's the daily conversation that happens with this coordinating mechanism that we have, where ACA is providing the leadership in terms of coordination, AHS, Covenant, EHS, ALA. We're all there around the table, and this is the conversation every day, is where are we, where do we have capacity, can we move someone? We've actually, we've taken even a drastic step in some cases where we've wanted to move people into vacant space elsewhere in the province, and they didn't want to go. And so we do have some authority under the Hospitals Act to require that. And so we have done that as well. So as the minister said, we have lots of levers. He has more levers than I do. I have some working, but most of this we're doing in a collaborative way. But we're using all of the things at this point that we feel we need to do to manage. If tomorrow we wake up and something changes, we still have room. Like we've I think canceled 8 surgeries so far this year. So that's another thing that we could do. We could ramp things down. Every day when we're looking at where we have capacity, though, back to your original question in terms of load leveling, we are moving patients out of the most pressured environments into areas with less pressure to do that load leveling. So that is happening.
Do you have a follow-up, Zoe?
Yes, thank you. And apologies for the misattribution there. My second question would be for Covenant Health, but just following up on Julia's question with reference to the other 2 deaths at Grey Nuns on December 22nd. Can you expand at all on what inactive treatment means?
Yeah, so as you all know, that I'm restricted in speaking about any specifics of any individual case, and so it makes it difficult to answer these questions. But in all cases, within the emergency department, related to those 3 deaths, they were actively being seen by health professionals of various sorts and types. And so we've reviewed all 3 cases. We've participated extensively in the quality assessment review, which we really applauded the work that Acute Care Alberta has done. We requested both their expertise and their impartiality in conducting those reviews, and this review specifically. And so, from our perspective, we continue to work collaboratively, ensuring that we give all information over to whoever is conducting our review. Would even extend to say, as it relates to the fatality review, we are looking forward to participating in that as well, because, again, objective, transparent advice is welcomed in all circumstances, because we are absolutely committed to learning from what has happened and ensuring that we provide the best quality, safest care possible.
Operator, can you put us to the next caller?
Your next question comes from the line of Alana Smith from the Globe and Mail. Please go ahead.
Hi there. Thanks for taking my question. I believe this is for Minister Jones. I wanted to go back to your comments where you said that there were some concerns and unanswered questions that you had related to Mr. Skrikumar's death. I know that you're saying you don't want to predetermine essentially what the inquiry will find, but I don't want to ask you, I'm not asking you to tell the future, but the government has framed it as an unprecedented step to order a fatality inquiry. So can you just tell us broadly, these unanswered questions, these concerns, broadly, what does that relate to? Is it a poor diagnosis? Is it the care that was received? Is it specifics about the hospital or the search system? Can you just be broadly, what were the concerns? Obviously something was serious enough that you ordered the fatality inquiry. Yeah,
first, after reviewing all information, I still had concerns and unanswered questions, and I think that's the whole purpose of a fatality inquiry, is to make sure that concerns are addressed and all questions are answered. And I have to respect that process. I want to be clear that I have full confidence in our frontline healthcare workers and our service providers. The reality of hospital care and emergency departments is that they care for sick people in the most dire of circumstances, and we do have a number of deaths every day in Alberta in emergency departments. This particular one, we did do a quality assurance review, and I did review all available information and felt that it was in the public interest to request a fatality inquiry so that it could be publicly and independently reviewed for Albertans.
Do you have a follow-up, Alana?
I do. I'm sorry to go at it again, but it feels like you've just repeated what you've already said when this question's been answered a couple times. So are there any details, even just broadly, that you can explain to us? What were these unanswered questions? What were these concerns?
I am not in a position to explain to the public exactly why this happened. So there's a number of contributing factors, no doubt, but that is the job of the fatality inquiry. So I think it would be inappropriate for me to speculate with incomplete information on what occurred, but I do believe, based on the information I've reviewed to date, that it does warrant the escalation to a fatality inquiry.
Okay, we're going to return to the room here. We're going to go with Sean.
Thank you. Minister, will you admit that your government failed to plan and build enough bed space, particularly in Edmonton, to meet Albertans' needs? Because everybody on that stage agrees that that's an issue, that may be the major issue here, and ultimately it is your government's responsibility to build and staff those beds, correct?
Thank you for the question. I will fully acknowledge that we should have more acute care capacity in the Edmonton area than we do today, which is why I initiated a long-term capital plan, a 50-year capital plan, so that we are no longer behind or reacting to pressures, but we have a plan in place to build the appropriate acute care capacity wherever it's going to be needed as our population grows and shifts and ages. We also, as you saw in the acute care action plan, very quickly after being appointed to this position, I launched the expansion of 1,000 acute care beds in the Calgary and Edmonton region for exactly this reason. I believe we need more acute care beds in Edmonton and Calgary, but there's also other things we need. We need to continue recruiting healthcare professionals. We've recruited 600 doctors year over year, 1,000 RNs, LPNs, and healthcare aides. So ultimately, yes, I am accountable. And yes, I believe that there could have been greater capacity built in the years and decades, frankly, prior to today. But, the government deals with competing priorities across the board. We have education, we have social services, we have other aspects of healthcare beyond acute care that also require allocations, and these builds take significant time. So, yes, accountable. Yes, wish we had more. The plans are in place. The construction has already started. The money is allocated, and we're going to begin addressing the gap in capacity that I think does exist in Calgary and Edmonton.
So on the political side, who is to blame for us being where we're at right now? Like, I saw internal AHS documents years ago that said the Edmonton zone was already short hundreds of beds, moving to thousands of beds in the coming years. So who's to blame here? Is it Premier Notley? Is it Premier Kenney? Is it Premier Smith? Is it a combination of all that we have starved our healthcare system of the dollars it needs to take care of Albertans today?
First, I wouldn't agree with the characterization of starving the healthcare system. It has received significant budget increases well beyond population and inflation growth recently, and I would expect it to in the upcoming budget. But certainly, what I'm indicating is that the system requires a long-term capital plan, so that these decisions are not reactionary, they are not political, and they are on time. In other words, a hospital bed tower should be there when the catchment area, the population, the demographics, the acuity requires it. And we have not had a 50-year capital plan in place. We're working on it today. In conjunction with that, bed towers are useless without people. So that's why I've initiated the long-term workforce plan. We need to have the ability to train the healthcare professionals we need, but also where they're needed, because, of course, if you train them where you want them to work, they're more likely to stay there. And we have to balance that with what we believe we can attract from other jurisdictions and internationally. So it's not, this is a complex, integrated, multi-billion-dollar system where millions of decisions are made. Those decisions could have been better. And our priority is to lay a foundation that will make better decisions and that the capacity will be there when it's needed going forward.
One final set of questions.
Just with regards to the triage position, I mean, when you sort of mention that, like, the current system is that you're seen by a triage nurse and then they're giving you, or you are given a score. I know, speaking with a lot of doctors, they mentioned that when patients are waiting upwards of 8 hours in the emergency room, their condition obviously worsens. One mentioning that a guy came in with the flu, and then by the time he was in 8 hours later, he had to be intubated and had gone septic. With regards to that, when you're saying sort of providing them care with what they need, is this, I guess, sort of what's different than the actual nurse? Are they going to be provided some level of care in the actual waiting room? Or how does this actually look different than the current system where they're given the same score that I imagine the doctor will give them?
Dr. Lowe?
Yeah, so great question. So I think the difference is what happens currently is a nurse would see the patient, they do the vitals, they give them a score, which is called a CTAS score, which is just kind of their acuity. Often the patient would go back to the waiting room, And we know that all CTAS scores are not the same. They're 1, 2, 3, 4, and 5. And so with the physician who's there, we'll be able to actually assess the patient in a broader way than that triage nurse can. And so that's brand new assessment. So this patient that you are speaking of, we hope that this triage physician will allow that position will allow that doc to actually reassess that person. And if you thought, kind of a little bit worried about that person, you could go and reassess them more frequently than that triage nurse would have the ability to do, given all of the other requirements on that person with people coming in on a continual basis to emergency. So it's new work, and I guess to answer your other question, is there care going to be provided? So you can initiate blood work and even do some diagnostic imaging tests that could be ordered from a patient sitting in a waiting room, so you can get care going, and that way you can kind of further stratify that patient that you cited. You might order an X-ray and say, whoa, there's a significant abnormality here. We need to get that person into a space more rapidly, which is much more than we can do right now, right? So
you got a follow-up?
Yeah, just a quick follow-up to that, and then a second question.
We just have time for the follow-up.
Okay, it's probably a yes or no question, but will that position then be a current staff member who will be like a current emergency doctor who would be scheduled, or is this going to be an additional position that's hired? Because given the shortage of doctors that we're currently seeing, to move somebody off that care to put them in a triage position.
Yeah, good point. So yes, it will be from the complement of physicians that work in that department, and we won't be taking a position, say, out of those who are working in the department to do this role. So it'll be an additional, an additive shift. We acknowledge that we're going to need to recruit for this, right? So that will happen over time because there'll be more shifts to fill. But it will be the docs who are currently working at all the hospitals that you heard that will start filling these shifts as they are able to do so. As an addition to the current staffing in that department.
Thank you, everyone. That concludes the time we have available today. If you have any additional questions or follow-up, feel free to reach out. My contact information is at the bottom of the news release.
Thank you.